This conference will now be recorded.
Hi, everyone, and welcome to the AnCan High Risk, Recurrent, and Advanced Prostate Cancer video chat for Monday, July 20, 2026. I'm Len Sierra, and I'll be moderating today with a little help from my fellow moderators, Rick and Dr. John, and from all of you, our well-informed attendees. As a reminder, this video chat is for informational purposes only. Nothing contained in this discussion should be construed as medical advice. We want to acknowledge and thank our sponsors, and they are Foundation Medicine, Novartis, Telix, and Blue Earth. I think I have that right?
Yep.
Okay. Very good. Then we'll get started with William Eggeman. Do you prefer William or Bill, or what do you prefer, Mr. Eggeman?
Yeah.
What?
I'm Bill.
Bill, okay. All right, Bill. How old are you?
77.
Okay. And are you a vet?
A veteran? No.
Are you? No. Where are you located, Bill?
Anchorage, Alaska.
Sorry?
Anchorage, Alaska.
Oh, wow. Okay. You're our second Alaskan, I believe. And how did you learn about AnCan?
Okay, so my friend Alfredo Chervinsky told me about it.
Okay, very good. And tell us how you were diagnosed and when, and by what type of doctor?
A family physician ordered a PSA, and that was probably a year ago, and that started on the slippery diagnostic slope. I ended up with a biopsy, prostatectomy, and I don't know if this is the right group or not. Alfredo told me it was. I had localized cancer, and prostatectomy seemed like a good idea. There was a PET scan determined that, so I had the prostatectomy. Margins were not clear, so now the PSA is creeping up, and I have another PET scan tomorrow, and then we'll decide what to do.
You had a PSMA PET scan before the prostatectomy?
Let's see, yeah.
And it didn't show anything outside of the gland?
That's right.
Okay. But then post-surgical, your PSA began to rise. What was your initial PSA, Bill?
I think it was probably 10. And then I had another one that was 12. And like I said, the margins were not clear on the past specimen. So I knew that there was going to be more.
Okay. And let's see. So you had the surgery. What was your grade group or your Gleason score?
You know, I think it was 3-4 or 4-3.
Okay. So you had the surgery. PSA was creeping up. What is it now?
0.122.
Okay. And was that like the first PSA reading post-surgery?
No, post-surgery it was undetectable. The next one was, I don't know, detectable. It was less than the current one of 0.122.
Okay. And what was the date of the surgery?
September 29th, I think.
Okay. So it's about 10 months ago, had the surgery, and now it's creeping up. And what is the, well, first let me ask you, who is your doctor right now? Do you have a medical oncologist?
No, I have a urologist.
And where is, what's his name?
Radiation oncologist, and I'll probably be seeing him again.
Okay, what is the name of the urologist and where does he practice?
He is in Anchorage, and his name is Josh Logan.
Okay, and so you have a radiation oncologist lined up or someone you've been consulting with?
Yes, I already met with him in the initial decision-making phase, and his name is Kasura, I think.
Is that with a K or a C?
K.
Kastura.
It's Cusano, Kusano.
Cusano, okay. And what hospital is he at?
Providence Hospital in Anchorage.
Okay. All right, so you have not yet seen a medical oncologist?
No.
Okay. Let's see. Let me ask you, did you have any genetic testing, Bill?
Oh. Yes. And
You had
nothing came of that. There was no significant findings.
Now, was that germline or inherited genetic test or somatic or both?
Inherited.
Okay, so you didn't have a genetic analysis of your tumor tissue from your biopsy? You did?
Yeah, that was on the, they got that on the needle biopsy, and then, of course, with the pathology, they had more tissue. I don't know if any more testing was done along those lines, though. I do know that the severity increased with the pathological evaluation compared to the needle biopsy.
Meaning you had some type of unusual cell morphology?
I don't know the details of that. I was told that the tumor was more aggressive than initially thought from the needle biopsy.
Okay, did they mention the word cribriform?
No.
Okay.
But what was mentioned was that I'm an intermediate risk, high in the intermediate category.
Right. So you're 4+3, what we call unfavorable intermediate risk. And so I'm not sure I understood your answer about the genetic testing of the tumor tissue. Did you say they found any mutations or not?
No, nothing was mentioned of mutations, no.
Okay. And so you've already spoken to the radiation oncologists?
I had prior to having the prostatectomy.
Uh-huh. Okay, what about post-surgery?
And I haven't seen him yet, but I'll see him soon.
Okay. Do you have any specific questions for the group here?
Not really. I am a physician, incidentally. I'm a family physician. Alfredo's
Sorry, what type of physician?
Family medicine.
I didn't get, did anybody get that?
Family medicine.
Family medicine, okay, thank you. You're a bit echoey. I'm sorry, I'm having a little trouble. Okay, any family history of cancer?
Yeah, you know what? Turn off that speaker over there. And that may make things better. My mother had breast cancer. My sister had lung cancer.
Okay.
Good. Hit the button on the left. Good. That's good. So this may include.
Much better now.
Yeah. Sorry about that. I didn't realize that.
Okay. So no prostate cancer on the male line?
No.
Okay. Okay. So I think I'll open it up to the group here, see who has comments or questions, or maybe I left something out.
So just a couple of things, Dr. Bill. It would be really great if you can get a copy of your surgical report and the post-surgical pathology, because that will tell you what exactly they saw. It sounds like they may have upgraded you from a 3+4 to a 4+3.
I think that was it. Yeah.
But it's really good, as I don't have to tell you, it's really good to have a copy of that pathology report, and especially to see if there's anything in the morphology, because it could impact the treatment, the radiation treatment that is going to that's going to be discussed. The second thing that comes to mind is what sort of treatment has the radiation oncologist discussed with you? How many sessions, hormone therapy, et cetera, et cetera?
All that discussion was before the prostatectomy. And I don't know, but the hormone aspect would have been pursued if I had done the radiation initially.
Right.
As I understand it from what he said at the time, hormone therapy will not be included if I do the radiation therapy after the prostatectomy.
That's not necessarily true.
I'm certain of that.
I'm sorry?
I say I'm certain of that.
Well, you may be certain, but
true.
you'd be going against NCCN guidelines, depending on which you are free to do. But I mean, we're certain that in many cases, hormone therapy is appropriate. So you may not choose to do it. That's a whole nother story. But you should be aware that in many cases, in follow-up, in salvage radiation, depending on when you do it, that hormone therapy is recommended depending on the pathology and the morphology of the pathology, anywhere from 6 months to 18 months or more.
Okay.
So that's why I'm saying that your post-RP pathology is important, and you may even want to get a second opinion on that post-RP pathology. And we can tell you where to go for that second opinion. We can suggest a couple of people who probably have the best eyes on the globe, prostate cancer-wise, for that second opinion. And there is a lot of debate. There's more debate now about whether to include hormone therapy or not. And we'll throw it out to the guys for you to hear, but it is a very hot topic. So let me see, was there anything else? I was just talking to, by the way, Alfredo. He called me right before the meeting. Do we have your email address, or would you like to receive reminders for the meeting here?
Oh, I would like that, yes.
Okay, so
I don't believe you have it, no.
Okay, so the easiest way for you to do it is there is something called a chat window. If you go to the, I see, it looks like you're on a telephone there, on a cell phone.
I'm on an
iPad. So on the, I don't know where it is on the iPad, but there are going to be two little squares, probably next to a little figure that has a 43. And if you click on that or tap that, it will open a chat window, and you can put your name, your email address. Alternatively, you can send it to us, and I'll give you, you can send it to info, I-N-F-O, info@ancan.org.
I'm just typing it in right now.
Perfect. Perfect. And keep an eye on the chat. There's usually a lot of action that goes on in there. So, Len, those were the things that immediately came up to me that we may have missed. Got it. Thanks, Bill.
Okay.
In response to what was said, I'm amused at, I think, insulated by my denial, of course, because I'm a human being. I hadn't really pursued a lot of the details. And I've been doing some reading, and with that, I was thinking I should go back and get all the op reports, all the path reports,
yes,
that have been done, and look at them, because as I'm reading, there's a lot of details I don't have answers for.
Yes. Listen, we'll forgive you for not having thought about it, because you're the patient this time, and oftentimes you don't think like a doctor when you're the patient. That said,
believe me,
we're not. That said, we're not going to forgive Dr. Alfredo for not having advised you. We'll make sure he knows. Okay.
Any chance to harass Alfredo's good.
Okay. Back to you, Len.
Yeah. So, Bill, when did you have that PSMA PET scan?
That would have been before the surgery, so before September 29th.
Okay. Anybody think that before he has radiation done, he should have another PSMA PET, being that he's past the 0.12 level? It's still kind of low.
That's going to happen. That is happening tomorrow, Len.
Oh, okay, great.
Can you give me something to write on?
All right, very good. Anyone else have any questions for Bill?
Thanks.
Comments?
Just 2 cents from John. Hi there.
Yeah.
Well, we'd be glad to look at most particularly the surgical path report. I think that would help us the very most.
Okay.
All right. Well, thank you very much. We're glad you're here, Dr. Bill, and we hope you'll be back next week. You know that we alternate Mondays and Tuesdays, right?
Oh.
Oh, okay. So the next time we meet will be Tuesday, 6 p.m. Eastern time.
And just another quick comment from John. There still is a little ambiguity in my mind about, Bill, whether you had genomic testing on your tumor sample. So if you could sort of clear that up by finding genetic testing reports as well. But we are reassured by the fact that even though you have a sister or a mother with breast cancer and a sister with lung cancer, we are reassured that at least in your germ line inherited, there doesn't seem to be any trouble there.
So let me follow up on that, Dr. John. Dr. Bill, have you had a Decipher test at any time?
What kind of test?
Decipher, DECIPHER.
I believe that's what was done with the needle biopsy, and that I thought that's what looked at the DNA of the tumor.
Okay, so let's just clarify this a little bit. So we are suggesting, to begin with, a germline inherited mutation test, separate from anything else. Do you know if that's been done?
Not.
Oh, sounds like yes.
He said he did have that.
Well, now we're talking about a Decipher test, and he may be confusing it with the Decipher test.
Well, I had the Decipher test, and then
Okay.
Remember that word and looked up stuff about it at the time. And then, right. And then I had genetic
testing. So you had
testing. Right.
So, okay, so that's good. So we know you're negative germline, but you had a Decipher test. Now, what was your Decipher? There's a score that comes back with that Decipher test. Do you know what that score was?
I don't recall. No.
Okay, so a couple of things. You want to get hold of your Decipher test and get that report and tell us what the score is, because that score is becoming a pretty good indicator as to whether you need hormone therapy or not. If you have a very low Decipher score, the indication is not to add hormone therapy. If you have a very high Decipher score, the indication is. In addition, there's another test called Artera, ARTERA, which is really designed for people like you, and it's an AI report to tell you whether you need hormone therapy or you don't. And all of these are covered by Medicare. Now, in addition, the Decipher report.
Hang on a second, sorry. Make it go away. All right, are we back?
I'm here. So we've lost your picture. Okay,
yeah,
we've lost your. Oh, now we got your picture back. Look, in addition, there is a very comprehensive report that is generated by Decipher, which has a lot of information and is really supposed to be for research only. And it can be obtained. Your Dr. Logan has to ask for it, and he can ask for a copy to be sent to you. There can be a lot of information, genomic information about your tumor in that Decipher report. Dr. John, could you give Dr. Bill an idea of what might be in that grid report? Because I haven't read them, but I know you're very familiar with them.
Decipher takes a look at 22 or 23 genes that have associations with different, mostly prognostic, in some cases maybe even predictive outcomes, and they base it on what is now an enormous database of gentlemen who have taken the test. Since you are really on the fence about conservative versus aggressive treatment, tests like Decipher or Artera AI, any little bits can add to the scale of conservative treatment or aggressive treatment. This Decipher extension called GRID might also give us some great ideas about potential sensitivity to hormone treatment, things like that. So it's more information for us and for you because you've got a treatment decision coming up. Plus, we're still wondering what your radiation oncologist is going to recommend. whether they're going to want to treat that whole pelvis or whether they're going to just want to treat hot spots on the PET scan or whatever. So a couple of decisions coming up. So all the details that you can get will help you make that decision.
Okay.
And Dr. Pierre, you have a question or a comment?
Yeah, Bill, welcome to the group. I did family practice for 20 years also. But the one thing that I wanted to mention is, in addition to your PET, and you may want to ask them to do a pelvic MRI, because if you have recurrence around the bladder, the PET scan is going to miss that.
The margin was at the bladder, by the way. I had an MRI initially, and it was there was some artifact because I have a hip replacement.
Okay, because
Okay,
one of the spots the PET scan will miss is bladder tumor from the prostate, because the whole bladder lights up on PET scan.
Right.
Right.
So, it gets really, really tricky when the margin is at the base there. And we've had a couple of guys where we've had issues and it hasn't been read real well. And it isn't particularly well picked up a lot of times on the pathology. I'm trying to think who, it might be somebody who's in the group right now. If it's somebody who's in the group who had an issue with a margin at the bladder, at the bladder neck, please put your hand up, because it's not coming to me right away who it is. Oh, it could have been Pierre. Dr. Pierre will talk to you in a second. That said, if you have a margin, it's probably one of the worst places to have a margin. So you have to be really, really conservative in how you treat that, because it's very easy for the cancer to go through the bladder and move to other spots. And so, you know, we particularly recommend, if there's a concern, I remember who it is now. He's not on today. It's a younger man who was treated at University of Michigan, and there was confusion. He sent his pathology out to Dr. Epstein, and we confirmed that there was, through Dr. Epstein, confirmed that there was an issue at the bladder. Bill Franklin, could you please put in the chat window for Dr. Bill the second opinions reference from our website, so he can go look at that second opinion. By the way, Dr.
No
Bill,
problem.
any link that's in the chat, you can just click on, it'll open in the browser. You can go look at it later, or you can download the chat where those 3 dots are. And
I believe
Bill,
you. Yeah, I'm not real good with some of this stuff, but anyway.
Okay, well, we'll give you a link, and anything you need afterwards, you can follow up through us, or I'm at RD@AnCan, or info@AnCan is Bill, and we'll get it to you afterwards. Bill's just put in the link to our second opinion stuff. So I think that here's the good news. We seem to think that we have a little bit of time to do salvage radiation. It doesn't, notwithstanding the pathology and the morphology, it doesn't appear to make a significant difference whether you radiate within 6 weeks or 7 weeks of your radical prostatectomy or 9 months. What was the date of your radical prostatectomy?
September 29th.
Of 25. So, you know, we have some time, and it's only just started to come back. So our feeling here would be we would navigate you to get all your information before you commit to do anything. Make sure you have as much information as you can. And then we can help you. We'll come back. You'll make a decision. And, you know, one of the things you can be asking Kusan is whether he wants to do everything with IMRT or whether he can do anything with SBRT, which will shorten the number of visits for you. That's an important question. Dr. Pierre, you had your hand up again, and you had some bladder neck involvement, right?
Yeah, I did. My margins at the bladder neck as well as vas deferens were involved. And on the initial path, which was done at Buff General, they just saw involvement of the right side of the bladder neck, which is the side that my cancer was on. When I had the pathology reviewed at Roswell Park, their pathologist said I had bilateral bladder neck involvement and bilateral vas deferens involvement. I was a Gleason 8 pre-op, and I was bumped up to a Gleason 9 with cribiform and intraductal post-op.
All right, thank you for that. Did that morphology, intraductal carcinoma, Bill, did that ring a bell with you? Did they mention that for you?
I don't know.
Okay. Okay, well, you're going to send us the pathology report, right?
Oh, I am?
I thought
Sure.
Dr. John asked for that. I don't know.
Right. I thought I was going to get it, but, and then sending it, how will I send it?
Email? Or, I don't know, am I wrong? Did you not ask for that, Dr. John or Rick?
Well, I
Well, we
think it
talked
will
about
be
it.
helpful. Yeah, send
Yeah.
it to one of us or bring it to group and we'll get some more details.
Okay. I don't know how I would, at this point, I don't know how to send to any of you. So anyway,
Okay, so we'll put some addresses in the chat window for you, so that'll help you. And ask for a copy. Dr. John just put his address in there, and we'll add some more. And ask them for a digital copy. When you call the hospital for your post-op, have them send it to you in digital form. It'll just be easy. You can just forward it on. Same thing for your biopsy report.
well, I think that I have a patient portal and all my information is readily available to me if I can navigate the patient portal, which
Sure.
I'm smiling because it's a pain in the ass and I have trouble with that.
Okay. So do you have grandkids?
No,
You're going to suggest to use your grandkids.
no. My wife is sitting there. I have her, and she's my tech advisor.
Okay. Well, you'll be able to download anything in your portal. So download it, make sure you know where it is, and send it on to Dr. John.
And the way I deal with the chat thing is I take a screenshot. I brought up
No.
the chat, take a screenshot. Now I've got that.
Okay. Well, if that's how you want to do it, but if you click on those three little buttons, it'll say you can download it. Now then you'll be challenged to know where it downloaded to.
Exactly.
We know. We know. We've run across you guys before.
All right.
You know, you could probably ask one of the nurses with the practice how to find your way around the portal and how to download things.
Thank
They
you.
should be able to help. Yeah. All right. Is it all right with you, Bill, if we move on?
Please, and thanks a lot for the information.
Well, thank you for sharing. Hope to see you
Come
next
on
week.
back.
Okay. So Bill Lawler, you're up now.
Thank you. Thank you. Just a quick update. 2 weeks ago when I was here, I indicated I had started the first part of the hormone therapy for my hormone treatment. The Orgovyx started, and then on this past Friday, I began the newbie for the hormone therapy. And the only real side effects I'm experiencing is a little bit of fatigue and more frequent urination with less volume.
Okay.
All right. How was your urination before you started the hormone therapy?
It was pretty good. It was pretty good. Yeah. But it was.
And I'm sorry, what were your prior treatments?
None.
None.
None, Len.
I was on active surveillance up until about 5 weeks ago. And I
went from active surveillance directly to hormone therapy?
Yes.
It's a little unusual.
So Bill was diagnosed in 2017 with a 3+4, and he's essentially been on active surveillance until recently, because his PSA got as high as 14.5 and PSMA found a lesion in his iliac bone.
Okay. Just that one bone lesion?
Correct.
Did they suggest metastasis-directed therapy, spot radiation, whatever you want to call it?
They say it's so small they want to wait a period of months to see what the hormone therapy does for it.
Okay.
Okay, and so I'll just fill this in, Bill, because I do it very quickly. We got him from MGH over to get opinions from Atish Chowdhury and D'Amico. And D'Amico wanted to throw the kitchen sink in terms of radiation. And Atish said, no, let's go slowly. Let's take a look. And by the way, if you need radiation, you don't have to come in here. You can get it locally. They're just as good. We'll help you design it, et cetera, et cetera, et cetera. So now you sort of know as much as we do. And so that's where we are.
Okay, so Bill Lawler, are you just giving us an update, or do you have questions for the group?
No, I was just giving you the update and looking for any feedback about the what is it typical of
the urination. Dr. John, you have thoughts on the urination issues?
Well, no, that was just my slow reflexes coming into play. I just wanted to know if there has been a new PSA since the last time we talked to you. But as far as the urination is concerned, it sounds like you have, what might be called lower urinary tract symptoms, which is there's some obstruction in the urethra, and it's making the stream weaker, and it's probably making it harder to fully empty your bladder, which therefore means that you're going to be going to the bathroom more frequently. There are medications for this. It's very common in men our age. I don't know what to say about the chances whether that it has anything to do with your prostate cancer or not. I just don't know. It's just very common to have hypertrophy of the prostate and those exact symptoms, and get medical treatment for it. But you just have to be reassured that this has nothing to do with your prostate cancer.
Got it. So who should I follow up with that on? The medical oncologist or the the urologist.
See, that's a good question. I'd like to ask some other people in the group what they think about that. The urologist can do studies of the urine and urine flow in your bladder, can do an ultrasound, can even do a cystoscopy and make a good diagnosis. Whether a medical oncologist has the tools other than PSMA PET scanning to identify whether there's any cancer in the way of the urine, that it would be a kind of a whole different approach. What do some of you other guys think about whether to go to his urologist or his MO first? I'm kind of inclined to say urologist, but what do you think?
So I think I'd agree with you, but I'd keep Dr. Atish aware. So I would let Dr. Chowdhury know that you've got this issue. Here's our concern. Your prostate has never been treated. The first thing we're treating right now is the metastasis. So we may have issues in the prostate. Did you, when you had that last PSMA scan, did it suggest that there was any issue with the prostate? PSMA scan is not great for finding cancer in the prostate, but did yours suggest that there was any issue there?
No.
So ask Dr. Atish if he sees any issue in the prostate, because I would trust him. I don't know who's your urologic oncologist, Bill?
It's a French name, Dr. Matteau.
Okay.
He's
and
Master.
He's at MGH.
Correct.
So, I mean, he may be great. He may not. We don't know him. That doesn't mean anything.
Right.
But I would ask Dr. Atish to take a look at your PSMA and just see if, and this would be a great way to introduce it. Say, Dr. Atish, could you just look? Because all of a sudden I've had some urinary issues. And I'm wondering if you see anything there. At the same time, go to Dr. Matteau at MGH and tell him I'm having urinary issues. I think that would be my way. Len, what do you think?
I agree with that. Get opinions from both medical oncologists and urologists. I think John was thinking along the lines of, well, getting old and might have BPH, and that might be a problem, but he tells us that it was there were no urinary issues before he started hormone therapy. So that would argue against the BPH thread. But anyway, yeah, tell them both.
I mean, here's a theory. Here's a possible theory, Bill, and this can happen. Although, how long have you been on the hormone therapy? 2 weeks?
2 weeks.
Yeah. It's a little soon, but here's what can happen. The hormone therapy can kill off the cancer cells. And when the cancer cells die off, they can cause inflammation. So it's possible, I mean, it's a little far-fetched, but it's possible that we're killing off cancer in the urethra, and that's causing some inflammation, which is giving you the issues. But somebody like Dr. Atish would have a better opinion, and probably Dr. Matteau would as well. You've heard us say this before. We like Dr. Chowdhury, Dr. Atish very much, and we trust what he says. So maybe we have a bias.
Mm-hmm. All right. Thank you, men.
Okay, Bill. Thank you. Dr. Pierre, you are next.
Yeah, I'm lined up for radiation sometime in mid-October, and I had some concerns because they're probably going to be irradiating, the whole pelvis, basically. Definitely the lymph nodes, because I've got recurrence there, bladder neck, vas deferens area, and then the prostate bed. The concern was, since the prostate's gone, the vault is now empty, and I don't know how well they can avoid hitting some of the vital structures, because they can't use gel or any of those. So anyways, physicians tend to minimize side effects. So I wanted input from patients that have been through it. And so I contacted Rick, and he gave me the name of 3 or 4 of you. I've heard from Dr. John and Bill Franklin. And Rick suggested that I throw it out to the group here. For anybody that's had prostatectomy and then radiation because of reoccurrence, and what side effects did you have and how long did they last?
Jim Stewart, go ahead.
That's kind of similar situation. I had to start radiation May 11th, but in the workup, the doctor said there's no evidence of any disease in the prostate bed, so we're not going to radiate the prostate bed. We just did the 2 specific lymph nodes that showed activity. So that was, and when I talked to the radiation oncologist about it, he said, yeah, we're seeing more and more of that, where people don't do the prostate bed just because. So I just, that was my experience, that they did not do the prostate bed, just the 2 lymph nodes.
Okay.
Let's see, Neil, go ahead.
Yeah, so I had the prostatectomy 12 years before I had the radiation, and at the time my PSA was not very high. It was 0.5 or 0.7, and so I wasn't able to see anything on the PSMA, which we took prior to the radiation. So they, in fact, went ahead and I decided to get the radiation anyway, to try and block it off. And by the way, I had hormone therapy as well for a year. So we didn't have any specific place to go, so they did the whole bed. And I've had some side effects, some bowel issues that are continuing, but getting better over the last 2 years. And I've learned to live with them pretty much. So it's not that rough. Once in a while, you have to deal with it, but that's my experience.
Thank you.
And Jeff, and then Hank after Jeff.
3.5 years after my prostatectomy, I had to have salvage radiation when my PSA hit 0.2. They gave me a Lupron shot 2 months before the radiation. Back then, 12 years ago, they did it in 40 sessions, and I had no side effects at all. I went to work immediately after and worked a full day, never noticed it. 6 years later, I started having some incontinence, but I had no side effects of any type. Nowadays, they give you 20 sessions or a little bit more, maybe up to 28. And usually people have some urinary issues right away. I know a couple of people I've been working with recently had burning when peeing, and one other guy has diarrhea right with the second or third session. It varies a lot on how people react. It's the shorter number of sessions does cause a little bit more problem because they give you more radiation each time.
Okay, thanks, Bill.
Okay, and next, Hank.
Yeah, so I also did the radical prostatectomy. Mine was in 2017, and I did the salvage radiation about 6 months later because PSA went up almost immediately after the surgery. I likewise had 40 doses across whatever it worked out to time-wise. During the radiation therapy, things went actually very smoothly. No real problems. no urinary incontinence afterwards, so I was grateful for that. I have ever since had some amount of rectal incontinence where you just kind of got to be careful when you hit it. Not wait too long because you can just never really trust what's going to happen.
Thank you.
So like bowel urgency, but not prostatitis. Is that right?
Correct. And that's been ongoing for the past 10 years.
Just urgency, or are you leaking?
Yes, leaking and urgency, and it's not all the time. It's it kind of comes and goes.
Any other questions for the group, Dr. Pierre?
Have any of you developed lymphedema from the nodes being nuked? No. Okay. Thank you.
From the nodes, you had them surgically removed, did you say?
No, being radiated. I mean, I had nine nodes removed on the right, haven't had any problems. But the recurrence is on the right again, so they're going to hit the right pelvis. And I also have right retroperitoneal nodes, so they're going to hit that. And
We
because
see
I used to work, having worked in the clinic, we dealt with a lot of the complications of lymphedema, so I'm a little gun shy on lymphedema.
So we see it very occasionally and usually after a surgery is where we'll see the lymphedema and in the lower legs. But it's really, probably could count it on one hand, maybe two, in all the time we've been giving this support. It really doesn't happen very often. I'm thinking of one person who usually attends on a Tuesday who may have had an issue, but it's really, really unusual. Wouldn't you say, Len and Dr. John?
Yeah, it seems usually if they remove a whole bunch of lymph nodes, pelvic lymph nodes, that lymphedema may develop.
That's my impression also. And I've seen a couple of reports in the last year indicating that a very extensive lymph node dissection doesn't make people live any longer anyway, which kind of surprised me. So maybe we'll be seeing less and less lymphedema in the future.
Jimmy G, you have a comment.
I do. I'm the jackpot. I had surgery. I had radiation. I had total incontinence as a result of the radiation that necessitated an artificial urinary sphincter. I had the radiation after the surgery, even though I had non-detectable PSA, which is unusual. That was in 2019. I took a clinical trial. The idea was they thought that if you don't wait until a recurrence and you hit it preemptively, that could have some value. Turns out that doesn't really have any value, but they didn't know it at the time. And I found that having to do the radiation pretty close after the surgery. Had surgery, started on ADT a couple months later, and a couple months later after that started with the radiation. So I didn't give my body much of a break. Ultimately, though, what made me, I wasn't going to say any of that, but I ended up in the long run with bronchitis, epididymitis, and quite a bit of intractable lymphedema of the scrotum and the testicles and penis, which I live with to this day. That's the bad news. The good news is that I'm a little over 5 years in durable remission. So there's that. I haven't been able to find much information on scrotal lymphedema, that's for sure. You don't see any YouTube videos of guys dealing with it, that's for sure. And nobody wants to think about it, I'm quite sure. I don't think it's common, but it's tough to manage. I have a kind of a spacesuit contraption that cost $10,000. Luckily, my insurance paid for it. I get into it and I sit there for a while. I do lymphatic massage with my own hands, but mostly it's chronic and, you know, just kind of a nuisance. I've had hydroseals. I've had a lot of problems, but I'm good.
Thanks, Jimmy.
Thank you, Jimmy.
So I just want to say, Dr. Pierre, like I said, that's why I wanted you to bring it up in the group, because there's a lot of experience here. If there's anybody in the group you'd like to reach out to and talk to more, let me know, and I'd be happy to put you directly in touch.
Thank you.
Okay, Jim Stewart, you are up now.
Okay, I just had a quick update and then a couple of questions related to that. For background, I had a prostatectomy May of 2024. Everything was going on fine, and then late 2025, my ultrasensitive PSA doubled, so they that initiated some more diagnostic work. They did a PSMA PET scan and found 2 positive lymph nodes. That was the only positive finding. So in March 1st, they started me on Orgovyx, and then April 1st, they started me on abiraterone with some prednisone, started radiation May 11th, and I just finished that July 1st. My questions are related to is that my liver functions really kind of went off the charts starting in the end of May. I'm highly abnormal, and they're gradually, at first they took me off the abiraterone, they dropped a little bit. Now I've been off the Orgovyx for a week, and I don't know what effect that has had. And one of the plans is that if it doesn't come back to normal, I'm going to start on Lupron. And so those are the background for my 2 questions. Has anyone else experienced liver issues, liver failure issues, or liver enzyme elevation issues after being on ADT? And number 2, as people that have been treated with Lupron, what's your impression of that? I mean, I hear a lot of anecdotal things about how awful Lupron is, but you know, I don't know. And so I thought I'd put it out to the group. I've read the side effects, but I thought I'd put it out to the people on the front lines here.
Okay, go ahead, Dr. Pierre, and then Jim Marshall.
Yeah, I'm on Orgovyx and Abby also. I've been on it for 3 months, and after I'd been on it for about a month, one of my liver functions bumped up. Not, you know, terribly high, but you know, I was mid-range before I started, and you know, it bumped above the normal range. My medical oncologist at Roswell, as well as Dr. Atish, basically said, "Don't worry about it. That's the Abby, and it usually comes down." Now, I wasn't high, but it sounds like you're pretty high, so that's why they had to stop it. One question I have: were you taking the Abby on an empty stomach and waiting at least an hour before you ate?
Yes.
Okay.
And my levels at I don't know if the normal levels are universal, but the AST, the normal level is 0 to 40, and the highest went up to was 127. And then the ALT, the normal range is 0 to 44, and at one point it hit 296. So it was pretty things got pretty high there.
You bumped a lot higher.
Okay, Jim, go ahead.
Okay, started out on both of those. 2017, I was good for 2 months, and the liver function started to go bad on me, dropped me to 3 pills, and I was good for 5 years. Okay, now on the ADT Lupron, I was on it 5 years, tolerated it well because I exercised a lot. And I found that is the key for me. And hey, it was okay. And I'm on a 4-year treatment holiday now, so. It was worth it.
Good to know. Thank you.
Go ahead, Rick.
Oh, a couple of things. My ALT and AST were elevated, but not like yours. They were north of 50 the whole time that I was on Lupron. I was only on Lupron. Back in the day, they didn't give you a second, although I actually would have been eligible, but they didn't give you a second. So I was sort of used to it, but they weren't at your levels. I think that when you mentioned this last time, we said that you should be drilling down with Dr. Bose about this, because these are pretty high levels and it could have something else. So the first thing one thing I want to ask you is, have you gone back to Dr. Bose and what does he say? Second thing is this. There should be no difference between Lupron and Orgovyx. So I think last time when you raised it, were puzzled by why would switching to Lupron make a difference? And I'm wondering if you've had any discussions, because the side effects should be the same from both.
Yeah, no, and Dr. Bose is overseeing all this, and Dr. Carroll chimes in as well. But I don't have an answer to your question. I don't know why. They started the abiraterone first, and I think because it didn't drop what they felt was significantly enough, they said, well, let's remove you off everything. No alcohol. I was taking a prophylactic statin, real low amount. They said, stop that, just kind of stop everything, and let's see what happens. So. But I see him next week, so that's a question I will ask. To be sure, I'm new to the Lupron, so I don't know. I haven't done that much research on it, so I don't know the particulars. But that's certainly something I'll ask.
To answer your question about Lupron, the Lupron should be the same set of side effects. It just works in a different way to stop your testosterone, but it stops the testosterone, and stopping the testosterone is what causes the side effects.
Okay. I thought it might have something to do with the injection versus taking the oral pill, but definitely not.
It may do, but that's above our pay grade. So I can't think of anything. Now, when was the last time you had your ALT and when did you stop everything?
Let's see. I stopped the abiraterone June 10th, and they just had me stop the Orgovyx last week on July 14th. And
and when was the last time you had an ALT and an AST test?
They've been doing it weekly since the end of May. So I had my last one was on July 14th, and the AST had dropped to 62, and the ALT had dropped to 145. It's still both pretty abnormal, but
heading in the right direction, right?
Yes, they're trending the right way. Right. But they had yo-yoed a little bit at one point in time, so I think that's why they're being a little more cautious.
Okay, so I will be interested to hear tell us what happened next week, and maybe just getting off this will solve the problem. But I would also be wanting to rule out any other issues, and I might be talking. I mean, I don't know. I'm going to defer to the physicians who are in this group because we got a bunch of them. But maybe you should be talking to another doctor to rule out there's no other liver issues.
Okay.
Well,
Dr. John, you have your hand up, so let's go to you first.
Okay, and then Len, I hope. Rick is right that all these drugs as a class are have a chance of raising your liver tests.
Okay.
And, if the tests are still under 100, oftentimes you can just wait a little while and things might calm down without doing anything. Years went over 100, so people started looking for the culprit. So does it make sense to switch from one drug in the class to another in the same class? Well, oddly enough, it does. Sometimes two drugs that are almost identical to each other, one will cause a rash and the other one won't, or one will cause aches and pains, the other was it's very odd. So it is worth, now you got rid of the Abbey, it is worth changing from one to another. You're not in the kind of situation where you might just say stop everything and wait a few months because you got the BRCA2 going on.
Yeah.
You don't want to leave you completely unprotected. So I'm okay with the approach that they're taking, knocking off one thing at a time, measuring liver tests frequently. So as long as you're not sick, nauseated or jaundice or throwing up or anything.
No, I think that if things do go back to normal, the plan is to start the Orgovyx and start the abiraterone at a lower dose, either 500 or 750 rather than the 1,000.
Mm-hmm. Yeah, I like it. Len, you think?
Yeah, I agree 100% with you. Dr. John, thank you for those comments. And we'll go now to Eric. And Bob Schwartz, you had your hand up. Maybe Dr. John answered for you, but if not, you go after Eric, okay? Go ahead, Eric.
Thank you. I also was put on abiraterone soon after I'd had radiation therapy, and I too ended up with my liver enzymes going through the roof. So I was on 1,000 milligrams. That's just back in August of 2024. By the end of October in 2024, my ALT had gone to 286 and AST was at 106. Yeah, so my doctor said, hey, we're going to stop and let it calm down and then reassess. He came up with the idea that I should be trying 250 milligrams with a 200 calorie snack, and that the snack, if you take it with the abiraterone, will potentiate it. So a smaller dose would be warranted. So we tried that for 2 months, the end of which my ALT had gone back up to 306 and my AST had gone back up to 157, unacceptable levels. And it was at that point that we started taking a look at alternatives. What I ended up doing, I ended up going on enzalutamide for a while, but I had some side effects that were really uncomfortable, and so I switched to darolutamide, and that's where I'm at. Actually, I'm on a drug vacation right now, but I was on darolutamide for over a year, and that seemed to be tolerable and did the trick. And it was and I'm just kind of giving you my experience, that's all.
Thank you.
And Eric, was that when you went on to the darolutamide, were you also taking an LHRH drug, or did they stop that?
I was taking Orgovyx.
So you were taking Orgovyx right the way through?
Yeah, actually, while I was on the enzalutamide, when I was on the API, I was on Lupron, and I switched over to Orgovyx. Let's see if I have that in my notes here.
It's okay. It's not important. But you continued on the Orgovyx and the darolutamide at the same time.
Correct.
Right. And what happened to your ALT and your AST? Where did they go when you went to the darolutamide?
So first thing I tried was enzalutamide, as an alternative to abiraterone. And my AST and ALT went right down to 16 and 19. So it just eliminated any problem whatsoever. And it's been like that now through enzalutamide as well as darolutamide. No adverse liver enzyme effect whatsoever.
So one of the things I did suggest to use, we did suggest to you, Jim, previously, is that when you do go back on, you might want to switch away from abiraterone. Okay. So hopefully we'll see. And, you know, if you can get on to Orgovyx and darolutamide, that would be great. And if that's a problem, monotherapy darolutamide is something to discuss with Dr. Bose.
Bob Schwartz, did you want to comment?
Yeah, just a quick one. Jim, I just want to tell you, I started out with abiraterone, prednisone, and Firmagon. I was so glad when my doctor switched me from those three to darolutamide and Eligard. All right, the darolutamide works better. I can't speak to the Orgovyx. I've never had any experience with that. Now, I'd like to get off the Eligard, I'll tell you that, but I'll tell you, compared to Firmagon, I'll take Eligard any day of the week, any day of the week. Seriously, the pain threshold is much less. It's like a saber versus a pin stick, but it's going to hurt. But the other thing you got to carry through, I found it with all of them, which was the same, was there's fatigue. I found I have to take naps now. I'm starting to feel my age more or whatever, but you take naps and you have to fight through it and you have to do a workout. You know, Frank Calabre's over here. I'm not trying to speak for you, Frank. You can speak up when you want. I know you're not shy, but he'll tell you if you work out when you're going through this, it's better for you. You got to push yourself at times.
I'm at the gym 6 days a week. Actually, right now I'm riding my bike 3 days a week, but 3 other days a week I'm at the gym. So
yeah, add some resistance training, some weightlifting, and things like that, and,
yeah.
And you'll see the positive effect. We're not ever going to be the same as we were before this stuff started. This nightmare doesn't end, but we can handle it and go further with it. All right, and you're not alone, but you'll be there, and everybody will be here to chime in and help you with it. Okay.
Great.
All right. Thank you, Jim.
Thank you, Bob. We're going to go now to Danny Langford.
Yeah, I want to say thank you all to everybody for your input. I appreciate that.
Hey everyone, you ready for me, Lynn?
Yes, I am.
So quick bio update for anyone who doesn't know. I'm 50. Oh wait, I turned 51, so I'm 51 now. I was a Gleason 10, stage 4 metastatic to the lymph nodes and glands in the pelvic area. I'm on a triplet therapy path right now. I started darolutamide and Orgovyx. Those are Orgovyx and Nubeqa in December, and I'm currently on my I start my 5th out of 6 chemo sessions this week, so I'm nearing the end. I thought I was going to quit. My 3rd session just about killed me, it seemed. I got sick in the middle of it, and I'm actually, like I think a lot of folks, I have an allergic reaction to the docetaxel or Taxotere, whatever you want to call it. And so they have to pump me full of stuff just to keep that that reaction down. But I'm good now. I start that 5th session this week, and I'm in the home stretch on chemotherapy, and then I'll go straight to radiation after that. So that's kind of where I'm at on the update. I have a couple of questions. You know, I was kind of complaining about hot flashes, and I'm on 1,200 milligrams of Nubeqa per day, and the Orgovyx is like 300 milligrams per day. And I'm just, man, I was flashing like nonstop. I mean, 24/7, I'm sweating and uncomfortable and hot. And I found like the only thing that made me comfortable was just get outside and sweat. I mean, go walk, go exercise, just be in the sweat and immerse yourself in it, right? And I finally went on medical leave, and that made life a lot easier because I wasn't having to get dressed up and get on a plane and go fly to meetings and stuff. So that started about 10 days ago, which has been a blessing. It's awesome to not have to work and deal with this at the same time. So I complained a little bit to my oncologist about the hot flashes. I told him, I said, it's like nonstop, man. It's like 24/7. It never ends. And he said, well, let's cut your Nubeqa in half. And I go, oh, really? And so I thought, Well, that seemed a little quick and easy. And so I said, well, let me try it. I was a bit skeptical. I said, let me try it this 3 weeks because I get chemo every 3 weeks. And so I went on half the dose of Nubeqa from 1,200 milligrams a day to 600. And you know, I get PSA tested every 3 weeks when I do these chemo sessions, and I've been down below 0.03 the whole time, so it's maintained. But my question there is like, man, he was super quick to be agreeable to cut that Nubeqa in half, or the darolutamide. And you know, my next chemo session is coming up, and I'm going to report back to him that you know, the hot flashes, they still exist. They're just not as intense. They're not as like debilitating. I mean, to the point that, you know, soak the sheets at nighttime, you know, type stuff. And so my question there is like, what are your thoughts on that? Cutting that Nubeqa in half right now when I'm in the, you know, I'm in the middle of chemo. I start radiation right after chemo. And I thought that was interesting that he agreed to cut that in half right now. And I'm wondering why he was so agreeable to that.
Well,
oncologist.
I think it's unusual, Danny, that cutting back on darolutamide would provide any relief for hot flashes. I mean, that's the experience you have, I'm not denying it. It's just unusual. In most cases, I've been on darolutamide on and off for 7 years. I never had monotherapy. I've never had hot flashes from that. And I know a bunch of other guys who've been on darolutamide who've never had hot flashes from it. Highly likely that it's the Orgovyx,
yeah.
Any other LHRH drug, Lupron, whatever, that's causing the hot flashes.
Mm-hmm.
So if you want to, I would talk to him about what about if I maintain the darolutamide but cut back or eliminate the LHRH? Just have that discussion, see what he says. And
Okay.
Rick, you got your hand up, and then David.
I do. I've got a couple of things that you can talk to Dr. Antanarakis about, to raise with him. One is oxybutynin, which we seem to have found works pretty well. Originally, it was thought just to work on abiraterone, but now it seems to be appropriate even if you're on any second-line anti-androgen, any ARSI. So you can try it. You know, try it for a couple of weeks and see if anything comes out. Now, it has side effects, and some of the docs here can talk to you as to the side effects because I can't remember them. But you know, so you may have some side issues from the oxybutynin. The other thing I would suggest, in deference to all of our E2 people, is see if he'll give you an estrogen patch and see if that estrogen patch helps you.
We brought it up, Rick. I brought that up again, and I gently brought it up to him, and I said, you know, PRN as needed, microdose. You know, I kind of came in there nice and easy with it, and man, he stands fast on that deep vein thrombosis and all that other stuff. And I even brought up Dr. Shellhammer. I was like, hey, you know this guy, he wants to talk to you. And so he kind of laughed at that, but no, he kind of stood firm on that, and he didn't take the bait on it. So, I mean, I could press him on it a little bit more because I do agree, you know, even if it's as needed or super low dose of estradiol patching to try to mitigate these side effects of hot flashes, because they're not mild. I mean, I'm sweating my face off right now, and it's. Yeah. And I think you're right, Len. I was wondering, like, is it the darolutamide or is it the Orgovyx? You know, which one really contributes to the? I mean, it's the drop in estrogen that's the lack of it. That's where it really comes from. But from what I read, but anyways, that was my question. Is like I thought he was super quick to let me drop that Nubeqa down by half, and so I think I might just go back up because it didn't really make a big difference. It could be psychosomatic, or I feel like it did. Drop it down a little bit, but I just thought he was real quick to agree to that, and maybe I convinced him. I don't know.
So Danny, first of all, the other thing I really want to say is I am very proud of you for going on the medical leave. I really am.
Yeah.
I know you didn't want to do it, and
Right.
RJ talked to you, and we talked to you, and good for you. And stay on that medical leave until you feel better, and you will feel better. So good for you. I also will say, I don't know what the wife says, but you look pretty good without any hair. So,
it's bald as a baby's butt, and I'm going to share something that's a little bit TMI. But this is my kids.
yes.
I have 4 boys, and they go, Dad, you don't have any hair on your legs or on your body. You know, we were swimming, and they're like, there's no hair anywhere, and I'm like, yeah, there's no hair on my butt either. It's easier to wipe my butt now.
Well, you're doing great, and I'm really proud of you, and it's really great, and I can't wait for you to get back down here. I ran across. Oh yes, I ran across a guy. That's why I was thinking. I ran across last weekend. I ran across a guy who works for your company at the beach with his wife, and not at the beach, at the lake with his wife. And they came over and talked to me because I'd met them once before, and I was thinking about you as well. So I really look forward to seeing you here. Think about that, asking for oxybutynin. Try it.
Okay, I put a note here for it. I will say just a little feedback for the group. I know I'm maybe a little bit different demographic on working, but you know, that taking that time off from work, it removed that one extra stressor, that one extra thing that puts the pressure on me, that stresses me. It stresses the body mentally and physically. And once I remove, because like after that one chemo session, I got super sick for about 3 weeks. I mean, it was really bad, worst in my life. And I said, okay, I got to take this time off work. And so, you know, doing chemotherapy for any of those that are facing it or haven't done it yet, it's about balance. And you know, if you don't do too much, don't do too little, you got to exercise, you got to eat the right foods. And once I removed that work stress off my plate, it was a game changer. And so now I'll be able to finish this, I think, and get that 6th chemo session done. Last question, and I'll go on mute. I'm supposed to begin radiation. It's probably going to be, I think it's EBRT, external beam radiation, for 27 doses over like, what is that, 6 weeks or something. And I know, you know, I've got lymph node and gland lighting up on the PET scan. So SBRT really isn't an option for me, right? I mean, because of the metastasis.
Well, not exactly, because the SBRT can still be used for the gland.
Just for the prostate.
So I would be asking them, can we do SBRT just to the gland? And that will cut the number of sessions by half.
And that's the reason. That's the reason, is the timing and the length of duration of all the treatment, right?
Right. So talk to them whether you can do SBRT to the gland and the balance is IMRT. And with the IMRT, they may be able to hyperfractionate and give you a little more. So you can talk to them about that as well, because they have some flexibility in how much they want to deliver each dose, even with the IMRT. And I think it varies between about 1.5 grays and 3 grays. By the way, I also learned that the gray measurement in the UK is different to the gray measurement in the US, gents.
Tell us about that. In what way?
I don't know the difference, but it came up recently that 60 grays in the UK is equivalent to 75 grays over here. We had a guy in our European group who's getting radiation, and that's how I found out. I didn't realize. I know it's true. I know it's true with milk that the US that liquid measurements are different, but I didn't know it was true with the grays. Anyway,
gray here is 100 rads, isn't it?
I don't know. It's probably 100 rads there too, but it's just that the amount is different.
Oh boy.
Because you know. a pint's a pint here and a pint's a pint in England. It's just that the pint in England is 20% bigger. So if you go into a bar in the UK and you order a pint of beer, you're getting 20% more than you get for a pint of beer here. Just saying. Oh, we got a bunch of hands up. We got to keep
Hey, yeah,
going.
let's go to David, then Bob Schwartz, and then, oh, Jack took his hand down. Okay.
Hey, just a question before Danny finishes. Danny, where are you calling in from?
I'm in Minneapolis.
Okay. So pretty close to me. Good. I'm Eden Prairie.
Oh, okay. Well, nice to meet you. I don't see your face. Who's talking on another screen?
I'll turn my camera on. It just had.
Oh, everyone. There we go. Okay.
Saving the bandwidth. Yeah.
Gotcha. Okay. Well, nice to meet you.
And connect, guys, connect through the chat. If you want each other's emails, send him a chat message. And if that doesn't happen, you can send it to me.
Well, wait, why don't you sign up for the Real Recoveries with me? I signed up for it September 11th or 9th in River Falls, Wisconsin. So that was a recommendation of this group. Why don't you go with me? Maybe we can go meet there and do some fly fishing together.
So it's an excuse to go to Wisconsin. Never a bad thing.
All right. Well, I'm good, guys. Thank you for the time. Hey, wait, before I go, I didn't really get clarity. I should probably bump back up to that 1200 on the Nubeqa, right? Because I don't really believe that it's making a big difference.
That's
Go ahead, John.
Yeah, okay. I hope we don't give him opposite ideas, but that's what my hand was up for. I could see you're worried about that. I think it's okay to be at a lower dose for a while because you're on good, aggressive other treatments. Mm-hmm. What were you going to say, Rick? Probably the opposite?
No, I was just going to say we can't really tell you that. That's right. Between you and your doc, is what I was going to say. So you have to go talk to Dr. A. But since Dr. John's a doc, I'm not contradicting him. But to me, that's between you and your doctor. Here's the one thing I think I would not do. I would not double it up without letting Dr. Antonakis know if that's what you want to do. Or I would discuss with him. I wouldn't just do it.
No, not at all. This was a test to see if it reduced my hot flash symptoms, and I felt like it did minimally, but not enough to warrant dropping that dose by half. So I think we'll have that conversation this week, and I'll say I don't think it was worth it that much, so I'll go back up to it. And I was questioning, like Lynn said, that Orgovyx is it the root cause of it or not? But anyways, thank you guys. Glad to be back. I haven't been here in about a month, so
and hang in because Len may be telling us something about Real Recovery before we're done. Okay.
Sounds good.
Right now we have a couple of guys who want to talk to you. I think Bob Schwartz, you're up.
Yeah, Danny, I wouldn't give up on that estradiol patch yet. I've started estradiol back in February, the end of February this year, and I'll be honest with you. I was on the lowest dosage possible, and gradually I've been built up, and I'm up half of what I need to be to get to the full dose. It's making an effort. It's taking time, but it's well worth it. And from talking with Len last week, I learned it wasn't the Nubeqa that was causing my problems. It's the Eligard shot. So when I get up a certain degree on it, I'm going to ask my doctor to see if we can go on monotherapy with it, and just have the estradiol patch and maybe the darolutamide. But I wouldn't give up on the darolutamide yet.
Okay, I've got to appreciate that, Bob.
Okay, Neil, and then Dr. Jack.
Danny, I just went to Idaho for the Real Recovery. It's going to take your stress levels down a lot. And please enjoy it. It was a great experience for me. I met some guys with other than prostate cancer, and we just had a great discussions, and I recommend it to anyone.
I appreciate that. This cancer is a lonely journey, especially when you disconnect from work and you disconnect from friends and family and kind of hide yourself a little bit. And so I'm looking forward to making some new connections with people. So I appreciate the group.
And I am going to ask Len to talk about Real Recovery next, as soon as we get done with you. But Dr. Jack.
Just a very brief question. I'm confused. You said maybe it was a mistake. you said you were on 300 milligrams of Orgovyx. I couldn't figure out what that meant. Was that a mistake?
I'd have to double check. So I take Orgovyx once a day and Nubeqa twice a day. Nubeqa is 1,200 milligrams per day, so it's like 4 pills per day. Let me double check the Orgovyx. I thought it was 300. It may be 120.
120.
You might be right.
That's where I got confused.
You're correct. It's 120. My bad. Sorry.
Okay. All right. I thought because that would certainly cause your severe hot flashes if you would take it 300 plus. Okay, fine.
Yeah, it's 120 a day.
Okay, now, Mr. Sierra spent the last few days of last week trying to catch trout. We're not sure if he caught anything more than a tadpole. Bill Franklin came on specifically because he wanted to poke fun, and we're not sure. So since we've been talking about real recovery with Danny and with Neil, I would like Len to talk a little bit about real recovery and tell us if he caught anything more than trout, but what else he got out of it.
And actually, no one caught trout. Everyone was catching smallmouth bass with emphasis on the word small. I have a video of me reeling in a smallmouth bass and then holding it by the lip and to the camera, and my buddy saying, "Oh, she's a monster, Len." And of course, it was like, this big. So that's the fishing angle. However, real recovery was so much more than I expected it to be. I thought, okay, you got a bunch of guys with different cancers, and we'll hear a little bit about their stories. We'll commiserate with our misery, and just be a little bit of a brotherhood bonding type of thing. But we had an excellent facilitator, and I'm sure you will too, Danny, or whoever else is going, who asked us. We had these series of group discussions we called courageous conversations, and each one lasted about an hour, and the facilitator would ask very probing questions that forced us to do some deep reflection on how we felt about our cancer, how we're managing it, what kind of support we were getting, who is the most important support person in your life. I can't even remember all the questions, but I was really so glad that I don't care if we never went fishing, just having this facilitator bring out all of these emotions and stories from different guys. We had guys with gastric cancer, 2 with leukemia, 2 different types of leukemia, 2 different types of lymphoma, and I think the rest were prostate cancer, of course. So there was a total of 11 guys. But it was absolutely worthwhile. I'd recommend it to anybody who's willing to open up. You could get uncomfortable if you're not willing to do that. But having gone through psilocybin treatment, I was ready to open up to anything. But it was richly rewarding. Yeah.
So Len, the $64,000 question, because I know it was a great concern to you. How were the accommodations?
Yes, they were great. I was thinking, am I going to disturb guys getting up in the middle of the night? But we had our own private room with private bathroom.
Oh.
The meals, there was a chef on site cooking breakfast, lunch, and dinner for us. It was delicious. Every meal was delicious. You had no alcohol. This was something sponsored by the Trinity Retreat Center, something like that. Yeah, TRC, which you've probably heard of the Trinity Church in Manhattan, Lower Manhattan. It's been there for over 100 years. So apparently they get wealthy donors to do annual funding to support this effort. But yeah, the accommodations were terrific.
Okay. Well, listen, I'm sitting there thinking we got to get Dr. Jack and Dr. John to go on one of these. Each of them to do a little fly fishing. Neil S. Neil S. Anything you would like to add about your experience?
Oh, I think Len captured it well. I was, I've had this issue with prostate cancer for a dozen years, and some of these guys did not, and they had it's a lonely journey, as you said, Danny, and it was great to share some of the things that I've been through, but also to reflect. Len, as you said, there were questions they asked, which we had a great facilitator. Questions they asked, we spent the time to answer, and they gave us time to think about them, which was very gracious of them. We didn't have to answer right away. We would ask the question in the morning and have to talk about it in the afternoon. So there were some thoughtful answers. The accommodations were great. The one thing I would say, I was so impressed, there were only 6 of us in the program, but there were like 8 what they call fishing buddies, or 9 that showed up. These are guys that are experts in fly fishing, really experts, and I'm not, and I learned a lot, but they took their time from their weekend and their families and everything else to come out and support us in our endeavors. And they didn't participate in the questions or anything. They participated in the daily activity of fishing. And for them to spend that time away from their family was very, very humbling to me. And they were all 35 to, kind of around 35 years old. But anyway, it was a great experience. I would recommend it. Unfortunately, it's only one time you can do it, but because I'd like to do it again. But Lan, I think you hit it. It was a lot of reflection and a great experience.
So Stan Friedman is asking, where was this? Stan, if you look just above David D's remark and click on that link, realrecovery.org, you can find out all about it. It is a national organization that organizes retreats of 3 days, I think, relatively close to where you are. So Len went to one in Connecticut, so you'll have to wait till they do another one in Connecticut, or maybe you can find another one. You have to pay to get yourself to the retreat center and back. Otherwise, they cover all the expenses. And we've had a lot of guys who have gone, more this year, I think, than any other year. But Len's gone. Bill Franklin has been on one. Matt McKinn in Sacramento just went on one, and we strongly endorse them. Now, Man Up to Cancer is a kind of similar concept. They are the new boys on the block, but their volume is much, much, much higher. They have this big retreat, the wolves, whatever, the gathering of the wolves. I also feel they're a lot more testosterone driven than Real Recovery. But it is another option for a similar type of experience. But we would definitely strongly endorse Real Recovery. Len, if you don't have anything else to add, please feel free to go on to the next gent. But
yeah, just one quick addition to Neil made a very good point, which I had overlooked. The guides, or buddies, as they're alternately called, the volunteers. These people are beautiful people. Like Neil said, they're volunteering their own time. One of my guides was a gynecologic surgeon, a woman, 62 years old. She was taking time. I'm getting a message here. Switch to the new mic. Hear me?
No, just say no, Len.
I said yes. Can you not hear me now?
Yeah, we can hear you. We're lucky.
Oh, okay, good.
We can't see you.
Oh well, what I look like. Yeah, 62-year-old female gynecologic surgeon. We really bonded. It was wonderful. She was like my best friend for those 3 days. It's a great experience. Okay, so I don't know. Somebody else want to take over, and while I try and get my camera back.
I've got the list, so I'll keep going. And Don Rogers is up next.
Right.
Yeah, hi. Last meeting we talked about when should someone get scans when they're basically undetectable. I've been undetectable now. I'm 4 years into this journey. I've been undetectable since I stopped taking ADT 2 years ago. So I ran the question by Dr. Belusic at the University of Miami this last week. And he thinks it's very reasonable to have a scan once a year. So then we started talking about the various options of scans. And he's really hesitant to do a yearly PSMA because of the radiation issue. So what we decided upon is that, and this is something I've never heard even mentioned in this group before, to do a whole body MRI 1 year, and the next year do a PSMA scan, and that's what we're going to do.
We know some docs that are following that protocol. So we have heard it before. Any comments from anybody on how often to get scanned and what your docs say? Go ahead, Dr. John.
This is John. I really don't know the answer to this question. I'm very interested in it. I myself just got a traditional technetium-99 bone scan last week. I think, and my oncologist kind of disagrees, but I think yearly scanning is a perfectly good idea, even if you're in remission, in order to supplement your PSAs, because neither one are a perfect screening instrument, and it has been shown that people can reoccur radiologically without recurring biochemically. Now, having said that, what type of scan? And I don't think anybody knows. People are using clinical judgment in this matter. The most I could get out of my doc is a bone scan, less sensitive, but less persistent radiation probably. I think a whole body MRI scan is a perfectly good idea, but it's less sensitive than a PET scan as well. I just don't know the answer. I think Belusic is coming up with a pretty good compromise, and I wish somebody would do a long-term outcome study, but they won't.
It was clear in my talk with Dr. Belusic that he would go along with any I made, and he talked about the traditional bone scan. And after talking about all these things, we decided upon that. And it was he was very open for me having a scan every 6 months if I wanted it. We decided that yearly scans, MRI followed by the PSMA PET was the avenue that we're going to follow.
Jack and I were talking about this a very short time ago, in fact, and one factor that hadn't occurred to me is, are you comfortable spending quite a long time in an MRI tube, because it takes quite a while to scan the entire body, particularly if you're just at a 1.5 Tesla machine. You okay with that?
I'm okay with that, and the MRI is going to be a 3.0 Tesla. That's one question I asked too. I was well aware of that.
Okay.
And I've had long MRIs of my heart several times. So they were like 45 minutes to 50 minutes. And I have that done every 3 or 4 years.
Oh, okay, good.
So Len's back. I just want to say that we still have 6 people who need time. I will stay here for as long as it takes. Len has dispensation to leave whenever he wants, and when he leaves, I'll take over. And so don't hang up. If you ask for time, we will get to you. And if there is there anybody else who wants to say anything about scans before we move on?
Yeah, I just wanted to say something about the MRI. I've had several total body MRIs and in lieu of a bone scan, which seems to be a trend these days. That the technetium bone scans is sort of antiquated, and the MRI for bone marrow investigation just seems to be the sine qua non. So that seems to be the thinking, and I certainly would go with that preferentially if Belusic does decide to follow me, and I was gonna ask him about that if I can get the MRI again. The only thing I do dread is 2.5 hours or so in that narrow tube down at the University of Miami, and it's a form of torture. It's a very narrow tube, and
Okay, so here are the people that still need time that I have on my list, and I'm sorry, latecomers, we won't be able to handle you this week, so you'll have to come back next week. Bob R, Jeff G, Gary M, and Gao Shan. Only four.
Did we do Dan Moore yet?
No, but he left. He came back, and I think he's left again.
Oh, okay. And Jeff Markey, is he here?
Yeah, Jeff didn't ask for time.
He didn't? Okay.
Yep.
Oh, no, I thought you told me, Rick, he said he wanted to talk about AUS.
Oh, you're right. I did. You're bad. And Jimmy's left anyway, so we can talk about it next week. Dr. John will be here next week, and Jimmy's here, so those are our 2 main AUS guys. So we can talk about AUS next week. But you're up to Bob Reeder.
Yeah, I don't really need time to. Probably people need it more than I do. I was just going to give an update, but the main thing was to say thank you.
Go ahead and give the update. You got the floor.
All right. So just a quick review. I'm 67 this month. I had a radical prostatectomy 6 years ago. It was aggressive, reasons 4s and 5s, and there was no sign of it after the surgery for 5 years. And then it's crept back at low level. So just questioning what to do. So I've done a number of consults locally, looking to identify doctors. I reached out to Dr. Antonarakis at the suggestion of the team, so I would have both a radiation and a medical oncologist on the team. I have that now. Dr. Antonarakis would not take me because I'm, for his caseload, I'm sort of at a mild position, but I do have on my team another medical oncologist that is on his team at Masonic, who also works out of other hospitals in the metro. And I narrowed down to my radiation oncologist through recommendations from Antonarakis' office that were confirmed by folks in another support group locally who were former patients of the doctor that I'm going to start with. So a lot of thinking about, do I want to do radiation and ADT? I decided to move ahead with that. So under the guidance of my medical oncologist and at his suggestion, looking at all of my situation, I had a 6-month shot of Lupron on Thursday. And then tomorrow I go in just for my final targeting scans to come up with my radiation plan. Okay. It looks like his estimate before he does the plan is probably 36 to 38 sessions to keep the dosage lower. per
So,
visit.
First question, who is the GU medical oncologist?
His name is Dr. Jha, J-A-H, I think. It's either J-H-A or J-A-H.
And who's the radiation oncologist?
Daniel Watson, W-A-T-T-S-O-N.
Okay.
What time?
So, whoever recommended the 6-month Lupron shot loses brownie points in this forum.
Yeah.
We do not like 6-month Lupron shots for a whole number of reasons, not the least of which is not guaranteed to work in the last month. And if you don't respond well, you have no option but to wait 6 months or 5 months to make any changes. So we discourage people from that long 6-month depot shot. Just saying, Bob.
Yep.
It's too late. So.
Yeah, I looked at the risks and I'm okay with it.
Okay. Len, back.
Is Gaoshan still with us?
Hold on a minute. Anybody else want to say anything to Bob? I wasn't thinking of moving on.
Oh, sorry.
Just one quick.
And by the way, I just want to say I appreciate that comment. You know, I just weighed that decision a lot.
Hey, Bob, I would like to just say one thing, Rick, real quick for Bob.
Yes, please.
Since we're so close, I'll throw it out there, Bob. I saw your message in the chat. I'm at Masonic. I'm with Dr. Antonarakis. I've got a new radiation at Masonic. It sounds like we could share some notes. We could have a conversation if you want. I've only been on this journey for 6 months, but if you ever want to grab a coffee and share notes, I'm right down the road from you.
Yeah, Nick's probably good. This week's kind of tight, but you got my email, so just shoot me yours and we can connect.
Right.
Yep, gotcha.
And you're required to send pictures. Okay. Jim Marshall.
Question for you, Bob. Prior to the shot, did you get the pills and Casodex?
No.
I'm finding around here radiation types do not give the Casodex prior to the Lupron shot. And I try to tell guys that they...
Right.
Okay. Well...
No, you're right. Double whammy against... Who gave you the 6-month shot? Was it the radiation doc or was it the GU medical?
That was the medical oncologist.
Okay, so now he's got 2 strikes against him because we still think that a bicalutamide buffer is very important. And he gave you a 6-month shot without a bicalutamide buffer. He would not be somebody that we'd be referring to again. And I think you should mention that to Dr. Antonarakis, because if these guys don't get told, they keep doing the same thing. Now, what is the purpose of the buffer? When he gives a Lupron shot, it pushes up your testosterone before it pulls it down. And if you've got any hidden metastasis somewhere and you get a big boost in your testosterone, it can cause a problem. And whilst we don't think you have any issues, it's just good practice to give bicalutamide before. And we maintain that, and it should be raised. It's not good to get a 6-month Lupron shot without a buffer.
Okay, I'll do that.
So, anyone else have any comments for Bob? If not, I'm going to go back to Len.
All right. So I see Gaoshan is still with us. You want to go ahead?
Yes. Hi guys. Wanted to say today's my 73rd birthday, and
Happy
I've
birthday.
been on this journey for 14 years. And on July 2nd, I had a video chat because I changed my medical oncologist from Dr. Graff to Dr. E, and was the first time I had a chance to meet with her. Couldn't do it in person because she was on a trip somewhere else in the US, but we organized a video chat, and I have to say I really enjoyed it. She brought some points that I've never heard brought up before, and before my meeting with her, I already had a number of blood tests. My testosterone went up from 453 to 511 from a year ago. And my PSA still is stable at 0.12. So it's been over 2 years. It's been between 0.08 to 0.12. She also agreed that once I get in the range of 0.2, that we'll do some type of scan to see where we're at. She's positive that we need to proceed with that. I already have a new appointment with her at the end of January. She brought up the point that because my PSA is quite stable and I've been on this journey for 14 years, that she's right now less concerned about my PSA in terms of wanting to check, but she brought up the point of even though I haven't gone osteopenia, one of my scans is close, 0.1 away from osteopenia, which is my left hip. She's concerned about that and to make sure. And I told her, hey, my vitamin D level is 98. My magnesium, calcium levels, according to the blood tests, are high. I think it's still residual from the Eligard, even though it's been 2 years. If I go back a year ago and 3 years ago with bone scans, it definitely, that left hip has, I shouldn't say deteriorated, but the number has gone closer to osteopenia. But she wants to watch that and make sure that I'm taking certain supplements. She did not recommend at this point some of the bone builders that have been mentioned in this group, which I don't remember the names of, but she'll want me to get another bone scan in a year.
Yeah, you're not eligible for really for any of those bone strengtheners because you're no longer on hormone therapy.
Right.
If you're
right.
on
Exactly.
hormone therapy, she might add it.
Right. But at this point I'm not, but she said there's no reason to take it. Just keep taking the supplements. The fact that your vitamin D level is in the high 90 percentile. She's positive where I'm going at, and we'll just watch where my PSA goes, my testosterone, and go from there. But I have to say, I really enjoyed her, and all the comments I've heard about her came true, and I'm really glad to be under her care now.
We're glad you're with her. And how's the weather in Shanghai today?
Hot and humid.
Hot and humid. Okay, just like it is in a bunch of this country.
Right.
Thank you. Thanks, Gaoshan. Len, we still have.
We've got one more, I think. Gary.
Two more. We've got Gary and we've got Jeff G.
Oh, okay. I didn't get Jeff G. Go ahead, Gary. We can't hear you, Gary. Your mic indicates it's active, but we don't hear you.
We don't hear you. So let's go to Jeff G and see if you can work on that mic, Gary. Jeffrey, turn on your mic. No, we can't hear you either. What's going on here? We can't hear Jeffrey G and we can't hear Gary M.
I think it's go-to. It does weird things.
I think it could be go-to as well. Oh my gosh.
Can't hear you, Gary. Gary M. No, still can't hear you.
No,
go to your settings and then audio and see what you can do there.
Yeah, go up to the settings.
Yeah.
Go ahead, Len.
Yeah, that gear shape image, top right. Hover over it, it'll say settings, and then you have audio underneath that.
Yes.
Hey, there you go.
Can
say
you hear
something.
me?
Yeah,
Yeah,
we
We can hear
Okay.
Gary M. and Jeffrey G. You need to do the same thing. Okay, we'll come to you in a second.
Yeah,
he
quick
said he doesn't need time. He didn't ask for
Oh,
time.
you didn't need time. Okay, all right.
Yeah.
Okay.
Can you hear me?
So you're last.
Yeah, go ahead, Gary.
Yeah, quick update. Diagnosed a year ago, Gleason 9, PSA 90, went on quadruplet treatment, Nubeca, Orgovyx, the docetaxel, and then radiation this spring. PSA down to 0.01, so I've had a really good response. I'm interested in looking at switching to the estradiol form of ADT. Was wondering if there's a list of providers coming together and kind of a protocol for how to transition off of the standard ADT onto the estradiol patches.
Where's Dr. Paul when we need him?
He's never here on a Monday night. He's only here on Tuesdays.
Okay.
Well, does anybody remember the name of his website? That estradiol initiatives, is it?
Yes.
Yes.
Yeah, I'm looking at that, the videos and so forth.
Okay. Don't they have a bunch of? Don't they recommend doctors on there? I thought they did.
I'll have to look. I didn't see any earlier today. I'll check again.
I think that they have recommended doctors on there. So that's the first. That would be my first stop.
Okay.
My second stop might be to write to Dr. Shellhammer, and I'd be happy to give you his name. But the bigger issue is, especially given that you had triplet therapy, you've got to get a medical oncologist who buys into this.
Right. Yeah, it needs to be monitored closely.
It's got to be monitored closely, and you can't be doing this as a lone ranger and self-prescribing. We've told guys on here before, they don't always hear it and they just do it. But you've got to have a doc. Now, a lot of the really good GU medical oncologists still aren't buying into it. You heard that with Dr. Antanarakis. And I think Dr. Eleni is another one who doesn't think that way. I don't know where Dr. Schmulowitz stands on it. I just don't know. But who isn't Schmulowitz your quarterback right now?
Yeah, he's one of the group. So yeah, I saw a radiation oncologist today who I know prescribed to one of his patients in the same cancer center I'm in, but he doesn't do long-term ADT, at most like 6 months. And he's deferring to my medical oncologist. He said he would talk to him, but I've asked him about it before, and he's indicated he hasn't used it in his practice. So,
is that your local medical oncologist?
Yes.
Yeah.
Yes.
Again, I think that you have to pick one medical oncologist, and you got to stick with him. You can't cherry pick these medical oncologists to find the one that gives you the answer you want to hear. And I know you guys all want to do that. But for somebody like you, Gary, who was de novo metastatic with significant number of lesions, I wouldn't be playing around with this.
Right.
Yeah, you'd like to be on E2. Yes. So, Danielle would love to be, just get a little patch to help him with it. And he can't even get Dr. Antanarakis to go with it. So this is all early. And I don't think we have a lot of experience. Yes, what we know is that E2 appears from the patches study to be non-inferior, but that was for single monotherapy LHRH.
I see.
And why? And what these guys are telling you is, we don't want to give it to you in a doublet concept because we don't know.
Mm-hmm.
Now, there are some docs who may say, yes, we'll try it, but we don't know who to send you to.
Okay.
Given that there's a geographical issue, and I will tell you that most of our really strong GU medics who we like are not in favor of E2 yet.
Yeah, that's what I was afraid. Kind of resistance to it.
You know, when you say resistance, the reason is because there have been no studies at all whether E2 works as well when you marry it with an androgen receptor blocker.
Right. Yeah. You would stand to reason, though, that it would.
I don't know.
Yeah,
I mean,
it hasn't been proven.
I can't tell you. I just don't know. I don't know. You know, what would make more sense to me, if you're that concerned, is to get Dr. Schmulowitz to take you to monotherapy, because we know he does that. Why are you so eager? What is the reasoning? Why are you so eager to get off of the Orgovyx?
Well, I watched.
Are you on Lupron, or are you on? What are you on?
Orgovyx.
Okay,
Yeah.
why are you eager?
I'm having extreme fatigue. It's continuing, and you know, I think it's the hormone blockers contribute to that, along with the radiation and the chemo. So I don't know. I watched Dr. Shellhammer. What was his name? Mark. It's a PCRI conference a month or so ago. He did an interview of Dr. Shellhammer, basically his 20-year journey using.
Yeah, but he's not on a second line.
Right.
He's not on the second line. You see, this is the problem. People say, "Oh, yeah, that's for me," but you got to take oranges to oranges. And whilst you know, we love Dr. Shellhammer, we do, and we really respect what he says. He's not in the same situation you're in. He wasn't de novo metastatic. He didn't have high volume, right? Now, if you wanted to suggest something because of the fatigue, maybe go back to Dr. Schmulowitz and say, Dr. Schmulowitz, I'm having excessive fatigue. How would you feel about if I dropped the Orgovyx right now?
Welcome to Open Advanced MRI Northwest, the leading provider of stress-free open MRIs.
Let me mute Thomas Matika.
Yeah, I can check with Dr. Schmulowitz about that.
I mean, that's where I would go, because we know Dr. David Muslin is a Dr. Schmulowitz patient, and he's on monotherapy Nubeqa, darolutamide.
Okay.
And so we know he'll do it. Will he do it for you and your situation? How long is it since your diagnosis? How long have you been on the hormone therapy in total?
1 year. 1 year.
I think you got to stick it out for 18 months. At least before you have the conversation. If he said no, but come back to me in 6 months, I think that would be a reasonable reply. But he might say yes if you tell him, I've got severe, and you're exercising and doing all the other stuff. I know you are.
Yes. Okay. Yeah. That sounds like a prudent approach.
I think nobody likes it. We all of us have hated being on it, or most all of us have hated being on it. But the fact is, we got to stick it out if we want to stay this side of the grass. And yes, we've got other things that can help us. Like maybe you could go to E2, maybe it would be better. You know, maybe talk about See if Dr. Schmulowitz would give you an estrogen patch, if that would help you at all.
Right, right. Yeah. Okay. I'll follow up with him.
But you
Thank
know,
you.
stick with your main guy and work with him, and you know, you'll know from us what he does do and what he doesn't do. And in your case, I would be surprised if he will take you off the LHRH completely, but he might be.
Yeah. Okay. I'll follow up with him then.
All right, guys. Well, we managed to get through everybody with 22 minutes over. That's not bad. Is there anybody on here right now who needs time and wants to come in at the end who I didn't ask before? Since in for a penny, in for a pound, I'll stay on. Anyone else need time for anything?
I'd like to speak just for a second, Rick. Thomas Matika.
Yes, sir.
Okay, I just have a comment about the MRI machines, and Dr. E described that as torture to me. So I'm not too crazy about it, and I have claustrophobia. But there are other technologies. There's something called an open MRI, not quite as good imaging from that, but there is also something called a wide bore MRI. It's still a tube sort of, but it is much wider, more expansive, and it is advertised as addressing claustrophobia issues, if that's a concern, and not just lying still for a while. So because of my issue, I wanted to bring that up.
Okay. Has anybody who's left had an experience with a wide bore or an open MRI? David, go ahead.
I'm not sure it was exactly a wide bore, but I had an MRI at Fred Hutch, and I told them that I had some claustrophobia issues, and they said, well, mention that when you schedule. We have two different machines. One's a lot more open than the other. It may have been a wide bore.
Uh-huh. Okay. And how was it? Did you feel better in that machine than the other machine?
I did much better. The other machine, I had to, I freaked out and I had to reschedule.
Okay. So we have a few techniques that we've discussed over the years for MRI. I can't remember what they are, but if somebody's interested and wants to bring it up in the next session when we have a full complement of people, maybe we can talk about what you can do.
That'd be great.
But I like this wide bore. I like Thomas Matika's solution that seemed to work for David.
And for me too, Rick.
Okay. Have you had a wide bore MRI?
I have not. No, I've just come across it on the internet.
Well, when you've had a wide bore, you can tell us that it worked for you, because that would be two people with peer experience.
Okay, good enough.
Right. All right, everybody.
Good night, everybody.
Can I go home now?
Yeah.
Yes,
Rick.
Thank you. Bye. Good night.
And Dr. Bill. Oh, Dr. Bill left. I was just going to say, come back, Dr. Bill. All right. Good night, everybody.
Good night.
Good night.